Thank you for inviting me to come and give you a bit of an update of what's been going on in transverse myelitis. And I'm sorry I couldn't be here in the morning because of personal reasons, but I'll try to stay as much as I can. Can all of you see okay? The lighting is okay, everything is fine. So what I've been asked to, Barbara has asked me to take you through today, and I'm aware that most of you have been through these conferences several times over the years, and apologies if I'm sort of, saying the same thing again and again. You've heard it so many times, I apologize in advance, but I might assume there might be at least one or two people who haven't heard of bits of pieces. So what I will do is I'll start off with talking about the basics of inflammation, then I take you through what is coming through. So, so this is where I come from. How many of you are from Birmingham? Anybody from Birmingham? I'm just looking any of my patients are around or not. So two or three from Birmingham, or from the West Midlands region, not many. So most of you have traveled far and wide to get here. So I should probably welcome you to Birmingham, although it's now towards the end of the conference. So anyway, so this is where I work at the Queen Elizabeth Hospital, Birmingham. It's now nearly 5 years since the new hospital has been built, and we got a shiny new hospital, but obviously it's losing its shine as we go along every few years. And what we also have in Birmingham is we have the University of Birmingham and the medical school next to the hospital, and where I do my neuroimmunology, which is the immune-related laboratory work, and it'll come about what sort of things we've been doing from transverse myelitis point of view in a second as well. So this is where I work. My main interest is, as I said, the immune system affecting the brain and the nervous system in general. So I deal with lots of people with myasthenia, muscle weakness due to immunology problems. I deal with people with encephalitis. So it's the first time I'm coming for a transverse myelitis talk. So I often give a talk to the Myasthenia Association and the Encephalitis Society. So inflammation of the brain and the muscle. So it was the only bit in the middle which I hadn't come through, the transverse myelitis. So I think this is the culmination of that. So that is where we start. And it's a big center. Those of you being to the QE might know that it's a very big regional neuroscience center. They've got around 34 consultants, probably more, depending on how you count them, because some of them are based in the periphery and come to the QE half a day a week or things like that. There are lots of MS clinics. I do a weekly neuroimmunology clinic, so that deals with things like neuromyelitis optica, myasthenia, stiff person syndrome, and a variety of other immune-mediated conditions. That is what I mainly deal with. Of course, I have a myasthenia clinic in addition to that as well. And our laboratory does quite a lot of tests, including the aquaporin 4 antibodies. I presume some of you might have NMO, some of you would have transverse myelitis, what we call as not otherwise specified, which is probably one of the main questions people ask. Why do you call transverse myelitis? I'll come to that in a second. Barbara has kindly sent me some sort of main questions which you want to be answered. So what I will try to do is, as we go along, I'll try to answer some of them. And I know we have a question and answer session later on, but at least if we can get through as many of the questions as possible, we will do that as well. So this is what I'm going to do. I'm going to briefly talk about spinal cord disease. And again, I apologize. I might be, saying what you know already very well. But I'll just briefly get through that. And one of the common questions which has been asked to me is, how do you diagnose transverse myelitis? And why is it that I've got A and you've got B and somebody else has got C? And how can you make a distinction between 2 or 3 of them or all of them? And I'll come back to that in a second. And one of the other common questions is, how do I know whether I'm going to have a relapse or not? What can somebody tell me? Am I going to have a relapse? Or I got a bit of tingling in my hand. Is that a relapse? Is that something else? How can I predict that? And of course, one of the risk factors of MS is transverse myelitis. I'll come to that in more detail later on. And what is the chance that I will get MS in 1 year or 2 years or 3 years or 5 years or 20 years or whatever? How do we know that? And that is certainly something we will talk about. And again, as a society of transverse myelitis sufferers and carers, I presume the acute treatment is probably not the main thing you're interested in, mainly the chronic aspects and what else can we do in the long term, which is what I will talk about. And again, in clinical trials, I'm concentrating mainly on the ones which is for patients who have already been diagnosed with transverse myelitis rather than having the first episode. But there might be some trials in which you can think about relapses and things like that. And finally, we would like to sort of briefly discuss about future treatment options, and often things asked to me are things like stem cell therapy and things like that, which is certainly something I would briefly touch upon as much as possible. And I know that we haven't got much time, but we'll go through that as much as we can. Again, spinal cord anatomy, I'll try to use the mouse rather than use the pointer so that it goes to all 3 screens. Hopefully that's okay. That's the brain. Again, apologies for repeating something that's supposedly simple, but and then the brainstem comes down the spinal cord. The spinal cord is sort of split as 2 parts or 3 parts: the cervical spinal cord, the thoracic spinal cord, which is the T-bit, and the lumbar spinal cord is a lower bit. In fact, the spinal cord ends at L1. Anything below that is a nerve root. So the spinal cord is only up to that level and nothing below that. So if you have a lesion or inflammation in the thoracic region, you're more likely to have paraplegia, weakness in both legs. Where you have, if you weakness in the higher part of the spine, cervical spine, you're more likely to get quadriplegia, meaning arms involved as well, because as soon as the nerves of the arms go out of the cervical spine, then it's just the thoracic spine left. You don't have any further arm involvement. And when it is very high up, like in C2, C3, bit of the breathing center is up higher up. If you remember Christopher Reeve, which I'm sure you know, he had some breathing difficulties because his injury, which was a horse riding injury, was very high up at C2 level. So that means you need Christopher Reeve is a superman. I'm sure all of you know that, but still. So that was very higher up. So depending on where the inflammation is or where the lesion is, the symptoms are different. And that is sort of a cross section of the spinal cord. And one of the other things what I'm often asked about is, how is it that my colleague sitting next to me has got weakness in the arms and legs, whereas I've got only numbness, and somebody else has got bladder problems and I haven't got bladder problems. So those are sort of different things, and that depends on where the problem is. So if you take the cross section of the spinal cord like that, you have different tracks going down and up the spinal cord. It's like a multi-lane highway, sometimes millions of highways going up and down, and some of the sensory tracks are tracks which send the signal up to the brain, go up, and then of course you have the motor tracks going down. So if I can get the mouse to work, so this bit, the corticospinal tract, is the strength bit of the spinal cord, where you give the muscles power, and the ones in the back called the posterior column, and a bit in the front, the one which is the pink purple color, it's the one which is sensory tracts. And depending on where the problem is, you can have a problem affecting the front of the spinal cord, in which the problem is predominantly weakness. Sensory involvement is less, although some spinothalamic involvement is there. So the sensation is predominantly spared if the weakness is in the front of the spinal cord. Sorry, not weakness, the inflammation is in. Similarly, you can have inflammation in the back of the spinal cord, in which the problem is predominantly sensory. You will be able to walk and do things entirely normally, but you'll have sensory abnormalities. So numbness, tingling, pain, paresthesia, those sort of symptoms happen depending on where the problem is. And then you can have something in the middle, in which you have a combination of a bit of sensory and a bit of motor weakness. And you can have a single side, unilateral, just one arm or one leg being involved, because you have inflammation only in one side of the body, of the spinal cord. You can have a whole spine involved as well, and then in which case you got a complete transverse myelitis, and that affects all modalities, including your bladder, your bowels, and sexual function. Then you can have an isolated inflammation purely affecting the motor tracts without any sensory involvement whatsoever, just weakness without any sensory involvement. Rare, but can happen. So that can happen either single side or both sides. Then of course around the spinal cord you have what is known as the dura mater, which is the meninges. People talk about meningitis and the covering of the brain. When you have that, you can have inflammation or most likely meningiomas, tumors in the meninges pressing on to the spinal cord from there. And of course you can have pressure from outside, either a trauma or an injury or a spinal fracture of some description coming completely from outside. That also can cause spinal cord injury, not typically transverse myelitis, but we need to understand how they happen. And again, this is the starting point, which I often say, not all spinal cord disease is transverse myelitis. There are a variety of other conditions, and I'm sure you know about this very well. And for the purpose of the talk today, we're going to concentrate mainly on the inflammation bit today, transverse myelitis. Even that is divided into so many different subtypes. You can have inflammation due to MS, inflammation due to NMO, or it could be a post-infectious inflammation. You had an infection, and then the body reacts to the infection, produces immune changes, and that causes problems in the spinal cord with inflammation. The critical thing is when anybody comes with weakness in legs or arms, legs and arms, or legs or arms, the first thing to make sure is there is nothing compressing, nothing pressing on the spinal cord causing a problem, because that is a surgical emergency. You need to go in, take it out, otherwise we're going to be in trouble in the long term. So that is why you get sort of urgent scans when people come in with weakness in both legs or with bladder symptoms. So, but that's mainly a surgical bit of it, so I'll leave that to one side. And of course, you can have other mimics of transverse myelitis. So you can have certain types of intrinsic spinal cord tumors which behave like myelitis. And sometimes you can have blood vessel changes. So vascular, meaning you have spinal cord injury due to lack of blood supply, or you can have blood clots in certain parts of the spinal cord. And of course, you can have certain toxins affecting the spinal cord as well. Again, I'll leave that for the purpose of the talk today. And how do we diagnose transverse myelitis? I'm aware that Ming and probably some of the other colleagues have spoken a bit about transverse myelitis early on in the morning. So, but the key thing which I tell medical students time and time again is history. History is the key thing in making a diagnosis. Everything else secondary. Even the examination is secondary. Even the tests are secondary. The scan is secondary. The CSF is secondary. History is key. So how did it start? What was the onset? Was it very acute? For example, something happening very acutely. You were perfectly okay. You went to the loo, for example, and then it collapsed to the floor. Very acute. That's what we call a hyperacute, which happens within seconds, within milliseconds. It has to be vascular, it has to be blood supply problem, like a stroke. Do you know why stroke is called a stroke? Stroke is called a stroke because that's why. That's why it's called a stroke. Bang! It comes like that. It doesn't come stroke like that. So stroke is called a stroke because it comes bang. Okay? And if you have a symptom happening acutely like that, there's hardly anything else. Of course, I'm excluding trauma. Of course, you fell down and broke your spinal cord. That's a completely different thing. But of course, that history is different. But without any other inciting factors, you get a problem acutely, that is a spinal cord ischemia or a vascular problem. Again, that is very critical. When you get the history, it's very critical. Also, in an ischemic event, or what I call a blood vessel supply problem, it happens acutely and then gradually gets better as time goes by. Whereas in inflammation, it gradually comes on, slowly gets worse and worse and worse, and at some stage it reaches a peak and then gradually gets better with or without treatment. So that is the typical inflammation history. So again, the variety of different things. Again, I'm not going to go through the whole thing, but that is certainly something we can distinguish based on history. Again, as I said, depending on whether it's motor or sensory or bladder involvement or autonomic involvement, I told you this spinal cord has different tracts aligned in different ways. We can sort of have an idea of which part of the spinal cord is involved purely from history. Of course, examination confirms our suspicion, and then there are other tests, which is what most of us sort of concentrate on, knowingly or unknowingly, saying, oh, do a scan, that's going to help us. But actually, you need to go back to the history to correlate with the scan. So that is where the importance is. And again, I'll come back to scans bit later on. CSF examination is useful in certain scenarios, and again, I'll come back to that later on. In certain scenarios, you can have a spinal cord tumor presenting as inflammation within inverted commas, and that is where things like sophisticated scans like PET scans are useful. And again, I wouldn't go through that today. Again, this is not something I want to talk about. Most of you have gone through this and suffered, and that's not what I'm going to talk about today. But what I would talk about is when I talk about transverse myelitis, I include all of this together as one group, unless I say specific. And again, transverse myelitis is actually a description rather than a diagnosis. Okay, and I'll come back to that in the next slide. So this is one of the questions. How do you know who has got what? I told you MS can cause transverse myelitis, NMO can cause transverse myelitis, inflammation can cause, post-infectious inflammation can cause transverse myelitis, and variety of other immune things can cause transverse myelitis. And the starting point of that, again, apologies for teaching to suck eggs to grandma sort of thing. Itis means inflammation. That is all it means. Myelitis means inflammation. That is all it means. It is not a diagnosis. It's just like saying, I've got a headache. It is not a diagnosis. It is a description of what something is got. So optic neuritis means optic nerve inflammation, meningitis means inflammation of the meninges, and variety of itis I've written down. I'm not going to go through all of them. So that is all it means from an itis point of view. The next slide is quite busy, but there are a variety of factors we sort of put in together. It's like a jigsaw puzzle. You put them all together and say, can I make a distinction? Again, this is very busy, and I'm not going to go through all of this. So just take an example. If somebody's got NMO, often the inflammation of the spinal cord is a long inflammation, what's known as longitudinally extensive transmyelitis or longitudinal myelitis. It's a long inflammation when, by definition, more than 3 vertebral segments long. So if you have 3 spinal segments, more than 3, by definition, it is called a longitudinally extensive transmyelitis or LETM. If you have that, of course, that is not diagnostic of NMO, but more and more patients we think that if you got a long segment transmyelitis, it is more likely to be NMO. They may or may not have brain changes, brain MRI changes. Previously, we thought brain MRI was entirely normal NMO. It is not the case. We do find patients with abnormal MRI brain scans. Then we talk about CSF protein. CSF protein is very non-specific. It is often raised in a variety of transmyelitis. It doesn't tell us much one way or the other. Although protein is often normal in MS, again, that is not diagnostic. People talk about oligoclonal bands all along. Say, I've got bands, what does that mean? Does it make a diagnosis of MS? I don't think it makes a huge difference. However, in about 80 to 85% of patients, the bands are positive if they've got MS. That does not mean bands can be negative. Bands can be negative in MS, and that does not mean bands cannot be positive in NMO or other transmyelitis. So that's certainly something we need to think about. However, things like aquaporin 4 antibodies are very specific. You hardly ever get aquaporin 4 antibodies in anything else apart from NMO. So that is the way it goes. And the last row is the most important bit. Quite often, it is quite difficult to make a diagnosis early on. And as time goes by, you probably will get much more handle to it. So you've got new lesions coming up, new brain changes happening, or you get an optic neuritis, inflammation of the optic nerve, and then the diagnosis becomes more apparent as time goes by. Time often tells us a clue, although we can get an approximate idea as we go along. And this was a patient we had recently, and one of the other things is, this is a patient who had a recent breast cancer, who has had an inflammation of the spinal cord. And I presume most of you would have seen, I insist on showing my patients their scans. I don't know whether you have seen your scans yourself or not. All my patients, I insist they need to see the scans so that they understand what is going on. So this white bit is inflammation. This dark grayish black color is normal. So anything which is white in this particular sequence, this is a T2 weighted scan, this is a T1 weighted scan. There's a slight difference between the two. But if you look at a T2 weighted scan in which the fluid is white, which is a normal CSF, and the white bit in the middle is this inflammation. And you can see the inflammation is pretty long. And again, as with experience, we realize that this spinal cord is swollen. It's got swelling of the spinal cord. In this particular scenario, 79 with a breast cancer, you almost always first think this is a metastatic cancer. So cancer going into the spinal cord, very well known to happen. And when you look at this, this is the post-contrast images. You can see that these lesions sort of light up. And this lighting up of lesions with an extensive edema and swelling of the spinal cord with a very recent history of breast cancer, you almost always think this is secondary deposits in the spinal cord causing the problem. However, because the lesion is long, so what we did, we checked the aquaporin 4 antibodies, and she's got aquaporin 4 antibody positive NMO rather than having metastatic spinal cord disease. And you can see how we could be fooled by saying it's all metastatic. If it's metastatic disease, it's palliative treatment. There's nothing we can do about it. So if this breast cancer is spreading the spinal cord, affecting 8, 9, 10 segments, there is nothing we can do about it. It is palliative treatment. When you got aquaporin 4, in fact, even before the antibody came back as positive, looking at the spinal cord lesion, we had a suspicion this is a turn of inflammation rather than a metastatic tumor. We gave a treatment in the form of steroids, and somebody who was complete grade 0 quadriplegia, no power in both arms and legs, is now walking about. So yes, she's not completely back normal, as most of you can understand. It's not entirely back. Again, given the extensive inflammation, it's not something I expect to completely back to normal. Again, age is a factor of how much recovery happens as well. But certainly from somebody would have been left as palliative treatment, sorry to use the expression, left to die, she's now walking and doing as reasonable movement as possible. So that is how we look at the diagnosis. Again, you get an abnormal MRI in about 85 to 90%. This is talking about pure transverse myelitis, not talking about MS or not talking about other subtypes. If you have sensory changes that are often seen in nearly everyone at some stage or the other, and pain is very common, and pain is often one of the main symptoms. Many of my patients come and tell me that pain is unbearable, and I've got some slides about pain later on. And depending on the type of transverse myelitis, the other question is, how often do I expect to have a further problem? Would I have a further relapse? Would I have any further problem? And it depends on what type of transverse myelitis it is. If it is an infection, direct infection, it's probably highly unlikely to come back again. ADEM stands for acute disseminated encephalomyelitis, which is inflammation of the spinal cord and the brain at the same time. Again, often a one-off phenomenon rather than having one after the other. MS is the big play here. MS, obviously, there's frequency of relapse is high. NMO is probably here, probably even higher up than MS, depending on how you treat them or not. And so depending on the type of the pathology, the relapse frequency changes as well. Again, slightly busy slide. What are the predictors of relapse? If somebody comes to transverse myelitis, can I predict the very first time they come to me? Can I say whether they're going to get multiple episodes or not? When you have long segment myelitis, I showed you the long segment spinal cord, it's more likely, none of these are absolute, but it's more likely you can have recurrent myelitis. If you have an abnormal brain scan or a positive CSF oligoclonal bands, you're more likely to have recurrent myelitis. If you got a systemic connective tissue disease like Sjogren's disease or lupus or things like that, you're more likely to get recurrent disease. Presence of optic neuritis, again, you're going into the NMO spectrum, more likely to be higher up in that graph of having relapses. The other common question is, I have some new symptoms. Is it my pre-existing symptom getting worse, or is it a relapse? How do I know? And again, this is always difficult, and that's always I say, ring me up and ask me if in doubt. That is the easiest thing to do. But there are sort of things we could potentially look into. In symptom exacerbation, it's almost always a pre-existing symptom. Having a new symptom as an exacerbation, obviously that word means exacerbation means something getting worse. Infection is a common trigger, and changes in temperature can make it worse as well. Usually it's short lasting, but doesn't have to be, but anything up to a few days can happen with symptom exacerbation. What we have to bear in mind is, as time goes by, when you have weakness, the spasticity, the stiffness goes up as well. And that can make you feel weaker as we go along. And that is sort of a progressive type of thing. Again, that is certainly something you need to be aware of. I'm sure most of you are aware of that. Spasticity can worsen gait over a period of time, which is not a worsening of a new symptom. But of course, that's a progressive history rather than acute, ups and down type of relapse. Neuromyelitis optica, I presume few of you have been diagnosed with neuromyelitis optica or looking after people with NMO. As I said, you need to have a longitudinally extensive transverse myelitis. It doesn't have to be, but that is the diagnostic definition. And you get optic neuritis, and the aquaporin 4 antibodies is quite diagnosed. It's present in more than 90% of patients, but might not be there in a small proportion. And the reason the optic nerves and the spinal cord are more involved is aquaporin 4 is a water channel, and that water channel is predominantly there in these two parts of the nervous system, and that is why these parts are more involved. So the optic nerve, which is what there is on the cross section or a coronal section of the brain scan, and this is spinal cord, you can see changes based on that. Pain is difficult. Pain is quite difficult to treat. It's very challenging to treat. I've got a couple of patients, I'm just making sure they're not in this room, a couple of patients who have got very severe pain, which is very intractable to treat. Despite whatever we have tried, it is difficult to treat. Of course, there are a variety of things we can do. There's always a balancing act. I can always take pain away completely. To be honest, I can actually take everybody's pain away completely, but you'll be completely drowsy, you won't be able to get up and walk. So it's always a balancing act here. So people always come and ask me, can't you take my pain away completely? Yes, I can, but you probably will be anesthetized and not being able to do anything. So it's always a balance between the two. So that is how we try to manage. And the other thing, which is also quite painful, is the tonic muscle spasms, so the contractures and the cramp-like symptoms, which is often very common. Certain drugs like an anti-epileptic medication, carbamazepine, for example, is very useful for that type of spasms.
Excuse me, what was that again?
Tonic spasms, sort of cramps.
What was the medication?
Carbamazepine, Tegretol, is also quite often useful for that. I wouldn't advise you to take a tablet without seeing a doctor, though. Yeah, I think I've got some slides about that later on. This is courtesy of Saiju Jacob. I think he's given a couple of talks in previously because the same surname, but we're not related. So we might be, I don't know, maybe in sort of 20 generations ago, we don't know. Anyway, so Anu has kindly given me his slides in which they've looked into patients with NMO and the pain affecting the quality of life. So essentially looking at how much pain is there and what sort of factors affect the pain. So it's essentially purely looking at neuropathic pain. It came, I think, in October 2014 is this journal. So of the patients with neuromyelitis optica, about 30 of them were on some form of neuropathic pain medication. And all the drugs I've mentioned, or I've just mentioned carbamazepine as CB said there, is there. Amitriptyline is probably the most commonly used one, and gabapentin, pregabalin these two are the most common. 25 patients were on that. And 2/3 of patients were in constant pain. It wasn't intermittent or in fact, more than 2/3, 3/4, 68 plus 7, 75% were in constant pain or constant pain with intermittent exacerbation. 3/4 of patients had pain as a predominant symptom. Pain intensity is more in females. Of course, this study looks at 32, 33, 39 females and 11 males. So it's more gender biased to females anyway. But even looking into that, females had more pain intensity. What that means, we don't know. But that certainly tells us that there is a propensity to pain to be a problem. And despite needing help to walk and have bladder problems and bowel problems, pain was considered the worst symptom. I cannot walk, I can live with that, doctor, I don't have a problem, I can use a wheelchair and go around, but the pain is the one which is the main problem. And that is something which consistently see in a variety of patients. And if you compare pain in MS versus pain in NMO, of course, this doesn't tell us in an individual patient, but in general, in NMO, pain seems to be much more prominent, and you probably need lots of medication to control the pain in NMO as opposed to MS. And that's something we consistently see. This is the tonic spasm I mentioned, sort of brief cramp-like feeling, and which is again quite painful, which can be seen in a variety, especially when they get better, starting to get better. So this is the next question. What is my risk of developing MS, doctor? And this is not an easy question to answer. What I often say is the longer we go from the first episode of transamyelitis, is the less likely you'll have MS. That is the easiest way to say it. So if you're 2 years down the line, your risk will be lower than you're 6 months down the line. Similarly, 5 years down the line, risk of developing MS is pretty negligible. So 5 years sort of cut off and say, and if you haven't developed any further events after 5 years, it's highly unlikely, I will never say never in medicine, but highly unlikely this will turn out to be MS. Looking at the first episode, again, as you can imagine, you come to me for the first time, you've got transamyelitis, and I say time will tell you the diagnosis or tell us what is going to happen. It's not good enough. You need to know now what is going to happen to me in 2 years' time. That is reality, and that is what everybody wants. So we can have some form of predictors. So if you have an incomplete lesion rather than a complete paraplegia, it's comparatively more likely to develop into MS. Similarly, asymmetrical problems, presence of MRI brain abnormalities, presence of oligochondral bands, again predicts the likelihood of going into MS. I'll put all these slides up onto you, so hopefully you don't have to scribble all these down, because I'm running out of time a bit. And depending on where the inflammation start off with, this is an MS study, depending on what the inflammation was as the first presentation, the likelihood is also different. And the reassuring bit from a transamyelitis association is transamyelitis is less likely to transform into MS compared to optic neuritis. 1 in 2 people with optic neuritis will go into develop MS, whereas only 1 in 5 will develop MS if you've got pure transamyelitis. So that is sort of a, this is from the study looking at the AVENIX. The other way, this is the optic neuritis bit. So if you have optic neuritis, inflammation of the optic nerve, and got an abnormal MRI, just look at the cumulative figures there. You've got about a third chance that you're going to develop MS within the next 2 to 3 years. Whereas if you've got a normal brain MRI, you've got an 8% chance. And bear in mind, if I go back to the previous slide, spinal cord inflammation is probably half the risk anyway. So you could probably half this and make it into saying this is the risk of developing MS. Again, it's not an absolute science, but that is sort of numbers I sort of play with. Acute treatment, most of you at some stage would have had IV steroids, I presume, which is the most commonly used. And you've heard of the STRIVE trial this morning, I presume. So I'm not going to go through that. Then plasma exchange is given if the treatment is not effective early on. Again, there's got a long list of things there. I'm not going to go through all of them, and I'm more than happy to talk through things if need be later on. But variety of therapy sessions, variety of things like functional electrical stimulation is useful to get weakness, better, make weakness better. Pain management, again, is an issue. You have a combination of antidepressants and anti-epileptic drugs, which are often used in pain management. Spasticity management, again, you probably have a session on spasticity at some stage, is also an important thing in managing that. Vitamin D, don't know is the answer. Certainly no harm in taking vitamin D. There is certainly good evidence that vitamin D deficiency might predispose to MS to some extent. The science is not absolute. In this whole, I'm sure 50% of us will be vitamin D deficient, if not more. That is just because we haven't got sun. We haven't got sunlight here, so we're going to have vitamin D deficient. If you're Asian, like me, I'm probably 80% likelihood to have vitamin D deficiency. So that is very, very common. So lots and lots of sunbathing is the answer to that. Okay. So this is STRIVE trials. I'm going to skip through that because I think you've had a session this morning on that. So I'm going to skip that. So what trials are we talking about in transamyelitis and NMO? Fampridine, did someone talk about fampridine recently or last year or maybe some stage? You have. Okay, so I could skip through that. So if you have gone through that, I will probably have gone through the same slides. Maybe, I don't know. Don't know? Yeah, okay, fine. This has come through Michael Levy, through Saiju Jacob. So it's sort of third-hand slides. But essentially, what happens is that the myelin sheath is the one around that, and what happens is the nerve impulse sort of jump from one node to the other. So from one junction to the other, it sort of jumps across, and that is how the nerve impulse the electrical impulse are transmitted. And when you have demyelination, meaning the myelin sheath being stripped off, what happens is there is dissipation or spread of the nerve impulse. So that means you don't get enough. So if you look at the yellow bit, that is normal. The yellow amplitude is normal. And the blue bit is when you have demyelination. You get a low amplitude and a slow velocity. You get slow conduction across. And this is mainly one of the reasons for that is the potassium channels, which are there at the nerve terminal. What fampridine does, or amperized dalfampridine, which I'll come to in a second, what it does is it blocks the potassium channels and prevents leakage of current. So that makes the nerve work better. And this has been studied in MS quite a lot, about MS and fampridine, in fact, and dalfampridine, which is a prolonged release fampridine. And what we find, the advantage in transamyelitis, I'm assuming the non-MS, non-NMO transamyelitis is often a single lesion and should be much easier to treat rather than MS when you have multiple lesions and multiple relapses. Fampridine, I told you, is a potassium channel blocker. It blocks the potassium channels, and that increases walking speed in MS in several trials we have seen. Johns Hopkins is doing a trial on fampridine. I don't know whether it's finished recruiting or not, but obviously you have to get to Johns Hopkins to get to the trial. That is one of the trials which is going on as we speak. This is sort of a crossover trial. You get either a dummy pill or fampridine for the first few weeks, and then you cross over to the other. So that means you're guaranteed to have fampridine at some stage or the other. So that is the way the trial works. And I update you, or some of us will update you at some stage what is the result of that. There are other trials going on. All of them are in the US. We were about to recruit for the eculizumab trial in Birmingham, but we didn't have enough patients to recruit, so we couldn't do that. I'm not sure whether, I think Liverpool is having one patient in the trial. I think it said there's one patient in the trial. Tocilizumab, I don't think anybody has been recruited in the UK, but it's going on in the Brigham and Women's in Boston. And there is a trial looking into pain management. As you know, the cannabis receptors, the cannabinoid receptors, Sativex is the common describer, and this is a different type of inhibitor which is being used for central neuropathic pain as well. So this is the final bit, and can I regenerate my spinal cord, doctor, is one of the most common things. Yes, it's a simple answer to that, but it is a yes with lots of caveats, and that is what I would like to say. So I think all of us would prefer to walk if we can, and if you have difficulty walking, and that is what. And again, I'm sure you've read this, at least 100 times, this article, and it is certainly coming up. But of course, these are a very sort of selected group of patients with selected type of pathologies, and that's certainly something we can look into. So what sort of things you can do? What happens if you have inhibitors of myelin? It inhibits the myelin sheath. So you inhibit the inhibitor. So that means the myelin sheath works better. So that is one way. You neutralize your myelin inhibitors, or you give things to promote growth. That's the other way of doing it. And the other bit, the last bit is of course the stem cell therapy and any sort of a transplantation of cells into the injured spinal cord and make it grow. So this is what happened. The BBC News is about the olfactory and sheathing cells. So that's what I think Poland and London was the site. So variety of transplantation techniques. In fact, the vast majority of regeneration techniques is a combination of all three. So it's not one alone, it's a combination of all three. A very good article by Professor Williams from Edinburgh. But this is a section of the spinal cord. This is the injury you get. You get cavitation forming, you get astrocytes forming around that, scar tissue forming. And what you could do is you can put a graft in, and you give some growth factors and growth inhibitor neutralization factors in, and it's a multiple of all these three makes the cells grow back again. This important point is you can actually improve that to some extent by just pure rehabilitation. Physiotherapy certainly helps with getting regeneration up again. So it's not just building your muscles up again, it is actually getting signals back to the spinal cord to get regeneration. So physiotherapy is actually very useful. So in fact, that is why the rehabilitated muscle bit is important, because it sends signals back to the spinal cord and makes the spinal cord work better. And there are a variety of compounds being studied. I'm not going to go through all of them. There are a variety of studies. They're all in very early animal experiment stages. So that's why I'm not going to go through that in detail. So you can either make them migrate better, mature better, and things like that. We are doing some work in Birmingham, but again, this is mainly of neuroscience research. It hasn't transformed into, translated into medical clinical practice yet. So we were looking at things like what sort of inhibitor signals are there which we can curtail and then hopefully improve. This is looking at both optic nerve inflammation and also spinal cord inflammation. There are some caveats to the regenerative therapies. Although cells might grow, we do not know they're going to grow and produce the same thing what you want. So you have a weakness inducing nerve which is damaged, you make the cell grow, it might actually resprout somewhere else and actually cause more pain because it becomes a pain fiber rather than a muscle strengthening motor fiber. So that is certainly something it is and only a very small proportion of nerve cells actually regenerate, 2 to 10%. It's not a big number. Of course, we're looking at billions of nerve fibers, so even 2 to 10% might be a big number. And they don't grow very far. They only grow a few millimeters. That is the other caveat. But again, as time goes by, we might be able to do more things. So stem cells is probably going to be useful because stem cells, you can make them proliferate into whatever way you want. So that is probably one way of looking into that. And again, some Japanese work into pluripotent stem cells, meaning one stem cell which can transform into any type of cell, is being currently undertaken. Again, because of lack of time, I'm just going to skip through that. This is the olfactory epithelium, which is smell cell, which is the BBC news article. The difficulty with stem cell research is, as a doctor, the first thing for my patient is I do not do any harm myself. Even if I don't treat you to make you better, the first thing I should do is I'm not going to make you any worse. Okay, I know it doesn't sound as good as it should, but that is the way it is. I should make sure I do not give you more disease by trying to experiment on things like that. And that's one of the problems with stem cells. Stem cells can proliferate into tumors and things like that, and that's certainly something we haven't got the full understanding of. And then we need to target the lesion. We need to get to the spinal cord. Spinal cord transmyelination is probably easier because it is actually a local lesion, a focal lesion. It's one single place. Whereas if it's a broad damage, it's more difficult. Neurodegeneration, for example, dementia, for example, it's much more widespread and it's more difficult to target it. And we need to specific neurological function improvement. Again, there are studies going on in Johns Hopkins. They're looking at 3 patients for safety and 3 for function. Very small study, recruiting now, and we'll await with interest what the outcome of that is. And finally, the role of exercise. As I said, exercise is actually very useful, not only to get your muscle strength up again, it sends signal back to the spinal cord and help in regeneration. So that's certainly very useful. If you remember that graph I showed you, or the diagram I showed you again, the rehabilitated muscle is extremely important to make sure the spinal cord regeneration happens even without any of the grafts and stem cell type of therapy. And that is where I'm going to stop, and if I can take questions now or after a few minutes, I'm more than happy to.